Good morning. There is no substantial treatment for patients in cardiogenic shock, which is the worst kind of heart failure. In cardiogenic shock, the blood pressure drops dramatically. It's less than 90 millimeters of mercury. The body is not being perfused. The organs are not being perfused, and therefore there is no urine being made. The person becomes almost disoriented, and also metabolic acidosis sets in. And the prognosis is grim. Despite all treatment, despite what we've had for the last so many decades, the mortality is as high as 50% at 6 months or 1 year. And nothing seems to work. Now, finally, there is a signal that a very complex procedure, which has been around for the last decade, which is called the transcatheter edge-to-edge repair of the mitral valve, just might work in a certain subset of patients of cardiogenic shock, and these would be patients with mitral regurgitation. Now, what is mitral regurgitation? Mitral regurgitation means that instead of the blood flowing forward when the heart contracts, when the left ventricle contracts, the mitral valve, which is the valve between the upper chamber, the left atrium, and the left ventricle, that does not work properly. And instead of the blood being pumped ahead into the aorta, a fraction of it is ejected back into the left atrium. So there is a regurgitation of blood. It, instead of going forwards, is also going backwards. And this causes major problems. There is a severe deterioration in the quality of life. Hospital admissions increase, and the lifespan is reduced. So therefore, the important thing is to tackle the mitral regurgitation. Now, coming back to patients with cardiogenic shock, a large number of them would also have mitral regurgitation, which is of course graded according to the echocardiographic picture. And these would be grade 0, which means there is no mitral regurgitation, or there is just trace mitral regurgitation, and that is grade 1. Grade 2 would be mild mitral regurgitation, grade 3 would be moderate, and grade 4 would be severe mitral regurgitation. Now, in patients with cardiogenic shock, we use what are called inotropes, which increase the blood pressure and maintain perfusion into the various organs in the body. There was, as I've said, no treatment per se. Before this, nothing seems to work. The balloon pump doesn't work very much. Maybe if you do an angioplasty very quickly in the setting of an acute infarction, that may or may not work. However, this procedure called the edge-to-edge repair by the transcatheter approach seems to work. There is a study which has been presented very recently, which has been published also, and this was presented in the TCT meeting of this year. And this had a very large number of patients with cardiogenic shock, 3,800. This was not a randomized study, this was an observational study. And this is recorded in a registry in the United States of America. And here in these 8,000, almost 700 patients of cardiogenic shock, what was done was this technique, this procedure was employed, the transcatheter edge-to-edge repair. And this was successful in about 85% of these patients, in the sense, the definition was that the MR had to be reduced. Remember, these were patients of cardiogenic shock with a mitral regurgitation, and most of them had severe or moderate mitral regurgitation. So the aim was to reduce mitral regurgitation by at least grade 1. That means you reduce it from grade 3 to grade 2, or from grade 4 to grade 3, but also you reduce the mitral regurgitation to a mild form, that is grade 2 or less. So 85% of patients, in 85% of patients, this technique could be done. In 15% of the patients, this technique was not successful. So the researchers then compared both these groups and followed them up for 1 year. And what was found was almost a 50% reduction in mortality at the end of 1 year. In the group in which the Teer, that is, I will call it now Teer, that is the transcatheter edge-to-edge repair, was successful in them, the mortality dropped to something like about 35%, whereas at the end of 1 year, the mortality was almost 55% in the group in which this technique was not successful. So therefore, this is a hypothesis generating data, and which demands that there should be more studies, hopefully randomized studies. It would be difficult to do a randomized study in a person with a disease of this magnitude, considering the costs involved. But there is a signal now that in patients with cardiogenic shock accompanied by mitral regurgitation of a moderate or severe intensity, this technique could possibly work. And most importantly, for the first time, we have a situation wherein a technique is actually reducing mortality at the end of 1 year. Now, apart from this, the other important thing is that there have been 2 big studies in patients with chronic heart failure and mitral regurgitation. That is secondary to the heart failure. Now, I must, of course, tell you that mitral regurgitation can be of 2 kinds. One is primary, which is degenerative, and the other one is the secondary or the functional mitral regurgitation, which occurs in patients with heart failure. What happens is that the left ventricle is dilating. There is because of this dilatation, there is a distortion in the anatomy of the papillary muscles and the chordae tendineae, which connect to the mitral leaflets. There are 2 leaflets in the mitral valve, and these then are not able to coapt. They do not close properly. So therefore, there is a leak, and this leak causes the mitral regurgitation. So again, now there were these 2 big studies. And before I mention the studies, it is also important to remember that in the degenerative kind of mitral regurgitation, or possibly the primary mitral regurgitation, there is a chance of surgical repair working, and also a mitral valve replacement working. But in the functional or the secondary mitral regurgitation, surgical interventions have not been successful. That means in such patients, a mitral valve replacement by a artificial valve or a repair of the mitral valve just does not work. So therefore, the importance of these 2 studies which I'm going to mention, one was an American study, both were randomized. These are not observational studies, therefore the importance of these 2 studies. The first is an American study called the COAPT study, which had 600 patients with mitral regurgitation, obviously pretty severe mitral regurgitation. These were patients with heart failure. The ejection fraction was around 31 to 32%. The NT-proBNP was in the 5,000s picogram per mil, so therefore pretty severe patients. The regurgitation orifice was about 40 millimeter square. The area of the regurgitation, that is the leak, the area was about 40 millimeters square. These patients were randomized either to Teer, that is this device, or to guideline directed medical therapy. And what was found was that at the end of 2 years, there was a 37% reduction in mortality in patients who had the Teer device employed, and a 47% reduction in hospital admissions. So therefore, the results were good. In fact, a lot of commentators called this result spectacular. However, there was another study by the French. Both these studies have been published in the New England Journal of Medicine, I think in 2018. The French study was also a randomized study. Here the patients were 300, and the regurgitant, the leak orifice area was about 30 millimeters. The ejection fraction again was about 31%. These 300 patients were randomized again to this device, which was the similar device used in the American study. And the other patients, the other group, that is 150 patients, were given guideline-directed optimal medical therapy. The French did not find any difference at 1 year. There was no difference in mortality or the need for hospital admissions, which means that the device did not work. Now, this was a slightly confusing situation, because now the Americans were saying that the device worked, whereas the French were suggesting that the device was not so spectacular. In fact, it did not work at all. So then there was an explanation given by the American researchers, and what they said was, look, our patients were probably sicker because the NT-proBNP was in the 5,000s range, whereas in the French study it was in the 3,000 range. Also, our leak was much more, which means the mitral regurg was much more. The orifice area was around 40 millimeters square, whereas in the French study it was just about 30 millimeters square. So therefore, and they also added that possibly the operators in the French study were not trained enough or were not experienced enough, because maybe that accounted for the results which they have provided, that the Teer device does not work in these patients with mitral regurgitation and heart failure. The ejection fraction, of course, remember, in both the studies was around 30 to 31%. Now, therefore, it is still not clear, it is not absolutely clear that whether this device, which is quite expensive, I would presume that it would cost about from 20 to 25 lakhs in India, a single procedure with this device, whether it actually works or not in patients with heart failure and severe mitral regurgitation. Now, keeping these two studies in mind, a study has been published now this month in Circulation, I think on the 2nd of October, that is just about a week back. And this study is a sub-study of the PROVE heart failure trial. Now, I have mentioned this PROVE heart failure trial in my video on the sacubitril/valsartan combination in heart failure. The PROVE heart failure trial was, again, a follow-up study. It was not a randomized study. What they did was they took patients with the heart failure who were already, almost 2/3 were already on an ACE inhibitor or an angiotensin receptor blocker. And the ejection fraction was about 28%, so severe heart failure. And they now gave them the sacubitril/valsartan combination to these patients, that is Entresto, or in India it's called Vimada. So in these patients, it was found that when the echocardiogram was done at baseline, at 6 months, or at 1 year, there was a tremendous increase in the ejection fraction. That increased by almost an absolute 9.5% on an average, which means it could be more than that. Now, this is the achievement in the ejection fraction with a device. If you put in a biventricular pacemaker, I have seen that the ejection fraction will increase by 5%, at the most 6, 7%, 8%. But this study, in which you are just giving a tablet, you're not putting in a device, which again costs about 6 to 7 lakhs in India. You're not putting a pacemaker. You're just giving a tablet once a day, which costs about 15 rupees to 20 rupees in India. You are increasing the ejection fraction by almost 9.5% on an average. So this is a big achievement just by a tablet. So coming back to the study, now the sub-study which is published now on the 2nd of October 2022 in Circulation, which is the leading cardiology journal in the world, they have taken about 720 patients, given them sacubitril/valsartan, that is Entresto or Vimada, and done the echo at baseline, at 6 months, and at 1 year. And then these patients now were having mitral regurgitation. This is very important. 65% of them had a grade 0 or 1 mitral regurgitation, and about 15% had severe mitral regurgitation, that is 3 to 4 grade, and about 20% had mild mitral regurgitation. What did they find? They found that as early as 6 months, the number of patients in the severe group had halved. That means they had dropped. That means patients with a mitral regurgitation of grade 3 or grade 4 dropped from about 15% to just 8.2%, which is a 45% drop. And this improvement was sustained at 1 year. Now, what does this mean? This means that if there is a patient with heart failure with an ejection fraction of about 30% or a bit less and has mitral regurgitation of the severe kind, that is grade 3 or grade 4, it becomes mandatory upon the clinician to wait for at least 6 months before that person is advised a device such as Teer. Right? This is very simple because a Teer, as I've said, will cost you 20 to 25 lakhs. And here we have a tablet, just a simple tablet. Teer is a complex procedure. There could be slight complications, though they are very, very minimal. I'm not advocating that you don't use Teer, but what I'm trying to say is that we have to select patients who would best respond to Teer by seeing which patients respond to Entresto, that is a sacubitril/valsartan combination. Now, if you take 10 patients and you find that they have heart failure, an ejection fraction of 30%, and severe mitral regurgitation, and you give them 1 tablet of Entresto, in fact 2 tablets, the dosage is from 50 milligrams twice a day to 100 milligrams twice a day, or even more. And if you find that about 50% of these 10 patients get a drop or a reduction in their mitral regurgitation, then your job is done. Now you don't need to subject these patients to the complex and expensive device. However, there will be patients who will not respond to your drug. These are the patients who would then benefit from the complex procedure. Now, who are the patients who would not respond or would respond to Entresto? That is not clear, because there was no difference in the results based on age, sex, ethnicity, or the grade of MR. The results were clear that from about 15% of patients with moderate or severe mitral regurgitation, when they were given a combination of sacubitril valsartan over a 6 months period, and then also at 1 year, 50% of them responded, 50% of them had a drop in their mitral regurgitation. They went down at least by 2 grades or 1 grade, and they responded to this therapy, and therefore they would not need a device. So the take-home message is that we have a new device called Teer, that is a transcatheter edge-to-edge repair, and which should work in patients with cardiogenic shock who have a very bad prognosis. In cardiogenic shock with a mitral regurgitation, we have found that an observational study has shown a reduction in mortality by almost 50%. In patients with the secondary or functional mitral regurgitation, one should initially employ a medicine, that is Entresto, which is sacubitril valsartan, or even an SGLT2 inhibitor, because we now know that an SGLT2 inhibitor also dramatically reduces mortality and hospital admissions in patients with heart failure with reduced ejection fraction. And therefore, I think before we have an absolutely rock solid, clear indication of the patients who would need a device, that is the transcatheter edge-to-edge repair device, one should employ these 2 big drugs in patients with heart failure for at least 6 months. That is sacubitril valsartan combination, which is called Entresto all over the world. In our country, it is called Vimada, and this is freely available. Or we use an SGLT2 inhibitor, which could be dapagliflozin or empagliflozin. These drugs also are freely available. Here the dosage is only 10 milligrams once a day. We use these drugs in these patients, wait for 6 months. If there is a response, if there is a reduction in mitral regurgitation, which will improve the prognosis, then very good. In case the drugs do not work in these patients, then we should suggest to the patient that there is a device available which would be effective in these patients. Thank you very much.